Okay. Good evening, everyone. So thanks for joining this meeting. The topic this evening is an approach to upper GIT bleeding, specifically variceal bleeding. And the presenter is going to be Desiree Moodley from Tygerberg Hospital. Also just like to say that GECKO is hosted by the Gastric Foundation in association with Project ECHO, University of New Mexico, and it runs every second Monday at 6 o'clock. The chat will be open for questions, and also if you have questions, just let us know, raise your hand or whatever, and we can maybe try and deal with them as we go along. All right, Desiree.
Okay, can you see my slides?
Yes, that's perfect.
Okay, so good evening, everyone. I'm going to be talking about an approach to variceal bleeding. Well, varices in general, and then what to do when they bleed. So just to start at pathophysiology, portal hypertension is a consequence of increased intrahepatic resistance. This is due to architectural impairment from cirrhosis, microemboli, as well as increased vascular tone from reduced nitric oxide. In the setting of portal hypertension, you get splanchnic vasodilatation, and this results in increased portal venous inflow. So the splanchnic vasodilatation results in an effective hypovolemia. This stimulates neurohormonal factors such as your renin, angiotensin, aldosterone system, which all results in sodium and water retention. The sodium and water retention in turn increases your cardiac output, and this also leads to an increased portal venous inflow. So portal hypertension can eventually lead to portosystemic collaterals. And these collaterals can occur at many sites. The ones we see most commonly, esophageal and gastric varices, but you can also get caput medusa, retroperitoneal collaterals, as well as hemorrhoids. In terms of the causes of portal hypertension, you can have prehepatic, posthepatic, and intrahepatic, with prehepatic being your portal vein thrombosis, your splenic vein thrombosis, and then posthepatic being your Budd-Chiari syndrome, constrictive pericarditis, IVC obstruction, right-sided heart failure, and then severe tricuspid regurgitation. Looking at intrahepatic causes, they can be further subdivided into pre-sinusoidal, such as primary biliary cholangitis and schistosomiasis, sinusoidal, such as with cirrhosis, and then post-sinusoidal as well. So how do we diagnose clinically significant portal hypertension? Well, the gold standard is actually by measuring your hepatic venous pressure gradient. How this gets done is that a balloon catheter is inserted into your cephalic vein or your internal jugular vein all the way to the hepatic vein. They then measure your free hepatic pressure in about 2 to 3 centimeters from your IVC. The balloon is then blown up and your wedge hepatic vein pressure is measured. And the difference between these two is your hepatic vein pressure gradient. Other measurements can also be done using this, for instance, your portal pressure gradient. And this is when you measure the portal pressure and your free hepatic vein pressure. And the difference between that will give you your portal pressure gradient. This is used more for tips insertion and to gauge response. So what do these hepatic vein pressure gradients mean? Well, normal is less than 5. Once it's more than 5, you have portal hypertension. More than 10 is where it becomes clinically significant. More than 12 is when your varices may bleed. And more than 20 is suggestive of when treatment may fail. But once again, we know this is not always available. Are there other markers, such as a non-invasive way to diagnose clinically significant portal hypertension? And yes, we can. So the Bivino 7 consensus says that we can also use vibration-controlled transient elastography, known colloquially as the fibroscan, which can basically correlate looking at where the fibrosis is from F0 to F4. Obviously, we're looking at a spectrum from pre-cirrhotic to cirrhotic and compensated to decompensated. And depending on the cause, there are different numbers that we can find. So just use this as a reference, depending on whether it's a viral hepatitis, non-alcoholic fatty liver disease, alcohol, primary biliary cholangitis, or autoimmune hepatitis, all have different values. But this can essentially tell you the stage of fibrosis you're dealing with. And then this is also from Bovino. But if your liver stiffness using a FibroScan is less than 15 and your platelets are more than 150, you can actually exclude clinically significant portal hypertension. If it's more than 25 in a patient who's got viral hepatitis or alcohol-related liver disease or non-obese fatty liver disease, you can rule in clinically significant portal hypertension. And then when you're dealing in the gray zone, so when your liver stiffness is between 20 to 25 and your platelets are less than 150, and when your stiffness is between 15 to 20 with the platelets of 110, this can also help you, as it shows these patients have a 60% risk of clinically significant portal hypertension. As I mentioned, the Bovino 7 consensus says this also with viral hepatitis, you can use something called the spleen stiffness measurement. Now, this is a special add-on to your FibroScan. Not every FibroScan has this attachment, but it can help you. So to rule out clinically significant portal hypertension, particularly in viral hepatitis, would be values of less than 21, and more than 50 would help you rule it in. In a patient who is intolerant or has contraindications to a non-selective beta blocker and doesn't want to necessarily undergo endoscopy, but they're in that gray area of liver stiffness being more than 20, but platelets less than 150, you can use a spleen stiffness of less than 40 to indicate a low risk of varices and possibly avoid endoscopy. I know the FibroScan is not available to everyone. Only certain centers have it, and that you can tools that you can use to kind of stratify risk, but those are not in this guideline. So when looking at the goals of therapy in terms of portal hypertension, we know there's a spectrum of disease with chronic liver disease that goes from compensated to decompensated. So initially what we want to do is we want to prevent clinically significant portal hypertension. Once a patient has developed clinically significant portal hypertension, you want to prevent them from decompensating. If they decompensate, you want to prevent further decompensation, including if they come in with a bleed. You want to make sure they're stable, prevent early rebleeding and death. And then once you stabilize them, you send them home, you want to do secondary prophylaxis to prevent them from coming back in with further decompensation and death. This is just an overview of all the medications that we do use in portal hypertension, and mainly they work on controlling the splanchnic vasodilatation, your cardiac output, and your intrahepatic resistance. But I'll go into each one now. So just to remind you, primary prophylaxis is when you have varices but no evidence of bleeding or previous bleeding, and secondary prophylaxis will be treating varices that have bled before. So when you have a liver stiffness of more than 25 or a liver stiffness more than 20 with platelets less than 150 for prophylaxis, and you scope your patient, if they don't have varices, you can actually scope them again in 1 to 3 years. If they have medium or large varices, you can either start a non-selective beta blocker or perform band ligation. In the middle, where you have small varices, you need to assess. So are there high-risk features, which I'll show you later on, red whale signs, or are there child pube B or C? If those are present, then you're going to repeat your scope. If they're not present, you're going to repeat your scope in 1 to 2 years. And if they are present, you're going to start a non-selective beta blocker. So in terms of choosing non-selective beta blockers, the preferred non-selective beta blocker in Bovino is carvedilol, and that's because of its alpha-adrenergic effects as well. And this means that it lowers portal pressure more than propranolol, as well as lowering systemic pressure. I know a lot of people get a twice daily dose, but it actually can be a once daily dose, and we titrate it to a systolic blood pressure. We don't really use the heart rate here. If you opt to treat with propranolol or nadolol, that's where you would go with titrating it according to your heart rate and your systolic blood pressure. Now, once you've got a patient coming with GIT bleeding, as we know, upper GI bleeds account for the majority at 70%, of which only 10% are variceal, and lower GI is 30%, with the anatomical differentiation being between the two being the ligament of Treitz. So once a patient has varices, it's actually seen in about half of all cirrhotics, and it stands to reason that the more severe your liver disease, the higher your risk of varices. So in a Charles Pugh A, only in 40%, but up to 85% in Charles Pugh C. They form at a rate of 5 to 15% per year, and up to a third of them will bleed at some point. And as I mentioned, bleeding is seen more if the portal pressure measures more than 12. This is just to remind you of the Child-Pugh score again. So you're looking at your ascites, your albumin, your bilirubin, encephalopathy, and your INR, and you get A, B, and C. And this not only helps you to risk stratify your patients, but also prognostication. So who's at high risk of bleeding from these varices? That would be your Child-Pugh C, the patients with hepatic venous pressure gradient of more than 20, if they've got large varices and high-risk stigmata. What is your risk of bleeding with varices? So with small varices, less than 5 millimeters or a grade 1, less than 10% a year. But once they become larger, so to grade 2 or 3, it's up to 30% a year. And the mortality is 15 to 30% a year. And if untreated, 70% will die within the year. So it's a very important preventable cause. This is just if a patient comes in with an upper GI bleed. I think this will be more covered in the non-variceal bleed. But essentially just deciding if your patient's going to be admitted or not, looking at things like their urea, hemoglobin, their vital signs, whether they have melena, syncope, and comorbidities. And if any of those are present, you're going to admit the patient for workup, as well as your Rockwell score, which is also to risk stratify patients, and that also includes endoscopy. But as I mentioned, I think this will be covered in the non-variceal bleeding talk. So when should you be scoping these patients? Well, if the patient has an upper GI bleed and features of cirrhosis, you're firstly going to adequately resuscitate them, and then you should scope them within 12 hours of presentation. Before you do any sort of procedure, there are pre-procedural checklists, intra-procedural and post-procedural checklists. The quality guidelines are out of the scope of this talk, but I just wanted to mention them. And then specific pre-endoscopic things that should be done in a variceal bleed. So as we know, ABCs, resus. If they're not maintaining their airway, either because of level of consciousness or massive bleeding, you need to protect it. Avoid aggressive fluid and volume resuscitation. So you accept a lower blood pressure in these patients and you target a hematocrit to 21%. In terms of transfusion, you're allowing an HB of between 7 and 8. Obviously, if someone's got cardiovascular risk factors, then you'll aim for 8. And there's no routine role for FFPs, platelets, or even cyclopacron. One should also give antibiotics for up to 7 days. What we generally use is ceftriaxone, 1 gram daily, and it's shown to have a mortality benefit. Also, in up to a quarter of suspected variceal bleeds, it may be due to something else. So they should be covered with a proton pump inhibitor before the scope. You can consider an infusion of erythromycin as well, 30 minutes to 2 hours prior if there's no contraindications. I know this is a Section 21 drug, so I'm not sure if anyone has access to this, but that can be used. And then what patients should definitely get is a vasoactive drug. So there are 4 drugs that are mentioned that can be used: somatostatin, octreotide, vasopressin, and terlipressin. So somatostatin, a bolus, and then you continue an infusion for 2 to 5 days. Octreotide is a synthetic analog that we use, a longer half-life, once again, a 50 mic bolus followed by an infusion for 2 to 5 days. And this is effective alone or with variceal band ligation at reducing rebleeding, but not mortality. And it's actually got a better safety profile than vasopressin or terlipressin, but there's no real mortality benefit that's been shown. Vasopressin, less preferred, and that's because of its extensive vasoconstrictor action, and you give it for only up to 24 hours. Terlipressin is a vasopressin analog with a longer half-life. What's to note here is that it's associated with hyponatremia, so you need to monitor the sodium and bear in mind that it can cause ischemic injury. So once you've got the patient stabilized, you're going to scope them. What are you looking for? So this is the classification of varices. So small size being less than 5, but using the modified Paquette classification, you can actually go grade 1, grade 2, and grade 3. So grade 1 basically almost completely flattens with insufflation. Grade 2, less than a third of the lumen is occupied, and grade 3, more than 50%. We also look for so-called red signs. As you can see, there's these little spots on these large varices in both these pictures. Once again, red whale sign there. There's some cherry spots on that second picture and a white nipple sign on the third. This just shows signs of either recent bleeding or high risk of rebleeding. And then I just included a picture on the far right, and that's a patient who's had a scope, who's had banding done recently. So there's ulceration there, and they actually can bleed from there as well. This is something I'm sure we've all seen at one point or another. Not always this clear. Sometimes there's just blood obscuring your field, and as soon as you've cleaned it out, blood fills up again. But this is something that you might have to deal with. So what you would do, endoscopic variceal band ligation. The actual technicalities of it, I don't go into, but once you've banded them, you need to repeat your banding, well, your scopes 2 to 8 weekly until you fully obliterated them. And fully obliterated means you've got grade 1 varices, and then from there you can go 6 to 12 monthly thereafter. Complications, we know they can get chest pain, ulceration, as we saw previously, bleeding, stricture formation, and they can perforate. After, if you've successfully gotten control of the bleeding, then post-endoscopically, if they're intubated, extubate them as soon as possible. Stop the PPI, risk of bacterial translocation, and there's no indication for it. Then you're going to continue your vasoactive drugs for 2 to 5 days, continue your antibiotics for up to 7 days, and then you want to start oral nutrition as soon as possible. You also might use lactulose or enemas, and that's to assist with gastric emptying to reduce the risk of hepatic encephalopathy. Now, what happens if you don't get control of bleeding? So that's treatment failure. So absence of control of bleeding or bleeding within the first 5 days, and that's seen in up to 15% of patients. Risk factors, again, your venous pressure gradient of more than 20, Child-Pugh-C, regardless of what you see on scope, or Child-Pugh-B with active bleeding on endoscopy. So there are several options. One of them is tamponade. This is the Senstarken-Blakemore tube, which is a temporary bridge for a maximum of 24 hours. I've never seen one. I don't know if we have one available. It's historically, there's one hidden in the ICU, but I have not found it. These patients should be monitored in ICU and ideally should have airway protection as well. But there's 2 balloons, esophageal balloon, a gastric balloon that get inflated. And it's because of that esophageal balloon that you can get that necrosis of the esophagus, and why it should only be kept blown up for 24 hours. One can also use a self-expanding metal stent. So this is the Dana stent that's made specifically for this. So this picture here is from their website. So that's the stent itself. And then I took a little picture of the video. There's a balloon at the end. So when you're deploying it in, you blow up the balloon, which helps the stent stay in place. And then you deploy the stent and pull out that introducer along with the balloon. That can work, but it's quite expensive. You can also just use a PTFE covered stent that we do have available. And I know we've used it ourselves. It's gotten us out of trouble once or twice. And the stent should stay in for up to 7 days. When those things don't work, you can consider doing a TIPS. So TIPS can be done either preemptively or salvage or rescue therapy if you can't get a hold of bleeding, control of bleeding. So preemptively is early, so that's within 72 hours, ideally within the first day. And this is if you have a bleeding varice or GOV1, GOV2, or those high risk factors that I mentioned earlier, the Child-Pugh-C, Child-Pugh-B with bleeding, or a pressure gradient more than 20. And once you put in the TIPS here, this is where you use that portal pressure gradient. It should be less than 12 after the TIPS, or reduce the pre-TIPS gradient by 50%. This is just a very old study that I put in from 2010 in the NEJM. They looked at patients who were free from uncontrolled bleeding after preemptive TIPS or survival, and they showed a benefit there. So in terms of salvage or rescue TIPS, so this is when you do TIPS when there's persistent bleeding despite pharmacological and endoscopic therapy, then consider TIPS. Also, if they rebleed in the first 5 days, you can repeat endoscopy and consider TIPS here. I know some centers don't have TIPS available, so once again, it's if it is available to you. Absolute contraindications, your heart failure, severe pulmonary hypertension, TR, polycystic liver disease, or uncontrolled infection or sepsis. And relatively, if you've got hepatocellular carcinoma, a portal vein thrombosis, and that's more for access issues, or severe coagulopathy or thrombocytopenia. And then when you have a patient who's got Child-Pugh-C, but more than 14 points, or a MELD more than 30, or a lactate more than 12. So a very, very sick patient, and there's no liver transplant in the foreseeable future. You really need to look at it as a case-by-case basis, because this is a bridge to transplant. So then it might just be futile. In terms of secondary prophylaxis, so we know that rebleeding occurs in up to 60% of them, of patients within 1 to 2 years after the initial episode. So we want to prevent that. So they should be on dual therapy, so beta blocker and endoscopic variceal ligation. You only should use monotherapy if there's intolerance or there's contraindication to a beta blocker. And if they rebleed on first line, that's when, once again, you can consider a TIPS. Looking at gastric varices, they occur in up to 15% of cirrhotics. They're less likely to bleed, but when they do bleed, it's more severe. And the primary intervention used here is a non-selective beta blocker. If they only have gastric varices, no esophageal varices, then you can consider doing a splenectomy for them. And then I've just put in a picture of the Sarin classification. So your GOV1 just involving your cardia, lesser curvature, your GOV2 involving your fundus, then your IGV1 involving just the fundus and not your OGJ, and your IGV2 anywhere else distal from the fundus. The most common is going to be your GOV1, and that we treat as esophageal varices. The most severe bleeding is seen in IGV1, and it's often seen with portal vein and splenic vein thrombosis. So when you have a IGV or a GOV2 beyond the cardia, you can inject it with glue or N-butyl cyanoacrylate, as you can see here. Another option, if you have interventional radiology available, is your balloon-occluded retrograde transvenous obliteration, also known as BRTO. And this is useful in GOV2 and IGVs that have large shunts. It does result in increased liver perfusion, and this can worsen ascites and esophageal varices. So this picture just shows, so you've got a large shunt here from your gastric veins to your left renal veins. So BRTO essentially just involves putting a catheter in all the way up to your left renal vein. They blow up the balloon to occlude that vein and then inject a sclerosant. There are a few variations to this. You can go anterograde, so that's a BATO. They can use plugs, that's known as plug-assisted, so PATO. They can use coils. And they say that an advanced GI endoscopist can actually, using EUS, inject glue as well into these and coils. This is just showing the procedure-related complications of BRTO at several centers, and the main ones being thrombosis, whether it be the renal vein, the portal vein, or the splenic vein, as well as PEs, and then a few had death. Looking at varices elsewhere, so ectopic varices, very rare, only up to about 5% of varices, and the most common site would be your stomas, in just under half, the duodenum in about a quarter, your rectum, and then other areas in 20%. And they can be quite difficult to access endoscopically, so we prefer a combination of TIPS and embolization for them. Got some pictures. So that first one is a stomal varice, and then you can see they actually coiled it. And then on the bottom, we've got some intestinal varices. Moving on to portal hypertensive gastropathy. So this is quite common, seen in 65% of patients who have cirrhosis and clinically significant portal hypertension. And the severity does correlate with your Child-Pugh score. Typically, they present with slow bleeding and anemias. And if you actually band ligate them, it may aggravate the portal hypertensive gastropathy. For first line, we use non-selective beta blockers to prevent recurrent bleeding. But if they become transfusion resistant or transfusion dependent, and it persists despite a non-selective beta blocker in endoscopic therapy, you can consider TIPS for these patients. These are just some pictures of that typical snake skin that you see, and at the bottom you can see how badly some of them can bleed. So take-home messages from this is that non-selective beta blocker is your first-line therapy for primary prevention. You need to risk stratify these patients and treat them accordingly. An acute variceal bleed has a 6-week mortality of 20%. So it's very, very important that you try and prevent it as much as possible and treat them adequately when they do come in. It's best treated with band ligation, vasoactive drugs, and antibiotics in combination. Consider preemptive tips if you've got high-risk patients. So those are the hepatic venous pressure gradient more than 20, your Child-Pugh B with bleeding on endoscopy, and Child-Pugh C. And then consider rescue or salvage tips in those who fail endoscopic therapy. Thank you.
Good. Thanks. You covered it very, very well. Are there any questions or any comments? If you do have
Marc,
a
I have a
question
question for Desiree.
Yeah.
Okay, can you hear me?
Yes, yes.
My internet is a bit unstable, so I was interested to see that you say you stopped the PPI. So because of the post-bending ulcers, in practical terms, people tend to continue the PPI post-bending. And I know anecdotally that patients have a lot of epigastric pain, quite severe post-bending, and actually keeping them on a PPI helps. So I'm just wondering what your comment is, and maybe Marc, you can tell me. That's the first thing. The second thing is the current role of statins in variceal bleeding. It was all the rage about 2 years ago, but I'm just wondering what the current guidelines say about using statins to, in addition to the other therapy, to reduce the portal pressures. Thank you, and a very nice presentation. Thank you, Des.
Okay, I'm going to start with the statins first, if that's okay. So just from what I've read, they say you can give statins if there's another indication as well. So if they've got dyslipidemia and cirrhosis, then you can consider giving statins. This is if I'm remembering the Baveno correctly. So that's what I got from that, but it doesn't really mention it anywhere in terms of variceal bleeding, just cirrhotics who have an indication for statin therapy. And then with the ulcers, I'm not sure. I'm just speaking from what I've been taught and what we do at in our unit with the PPI. So maybe Prof can jump in for that.
Yeah. So we used to continue the PPIs, but then the UK, there are UK guidelines on this and other guidelines that say that there's a higher incidence of C. diff if you routinely give PPIs. So we sort of stopped doing it. There is so like you mentioned, patients often bleed when the bands slough off. That usually happens on around about day 4, day 5 after you've banded them. So one of the other options is to give Alsanic. So we sometimes do that, especially as you know, around about day 3, day 4, when you start worrying about the bands sloughing off. Sometimes if the patient has you scope them and you know, there looks like there's contact bleeding in the stomach and all in the duodenum. Sometimes I put them on a PPI, but not routinely. Any other comments or questions? Neliswa?
Thanks, Marc. Brilliant presentation, Des. I really enjoyed it. And maybe also a comment on post-bending pain. I agree with Marc. Alsanic works like magic. Most of these patients are usually just prescribed them Alsanic by the evening, actually, and within 2 or 3 days they recover quite nicely, especially if they get more than 3 or 4 bends. And with regards to simvastatin, ASLD last year benefits, especially in metabolic associated or dysfunction steatotic liver disease. It's been shown that it reduces fibrosis. So in the long term, ideally, all these patients, whether they've got dyslipidemia or not, simvastatin should be initiated. Maybe a comment, and maybe I would love to hear Desiree's view on this. For centers that don't have transient elastography or fibroscan, would you be comfortable just looking at platelet count and maybe ultrasonographical features suggesting that there's fibrosis to screen these patients for varices? Would you be comfortable doing that? Because we have actually, I mean, it's sort of been our kind of standard practice at Groote. If you have somebody who has clinically cirrhosis with low platelets, we routinely send them for elective gastroscopy for variceal screening. And this was way before we had a fibroscan, and with our fibroscan now broken, I'm sure it's still a standard. What's your comment on just looking at the platelet count and or ultrasonographic and clinical features of cirrhosis and just going for that varicose screen to, for primary prevention of a varicose bleed?
So it's a bit difficult because, I mean, this is not anecdotally, I've seen patients with large varices and platelets of 250. So it doesn't always, you can miss patients with varices. I think I wouldn't not scope them if their platelets were above a certain number, if they had, advanced with clinical signs. I'd rather be safe and scope them, especially working where I do, where patients may be coming from far, might not have access to healthcare and things like that. I'd rather err on the safe side, because what you're looking at is one scope now, and then if they are, stable disease, you might not need to scope them for many years, as opposed to them coming in with a decompensation and bleeding. And I'm not sure if that's the answer you want, or...
No, I mean, I guess basically what I'm trying to say, which is what you're saying, is any patient who you deem clinically has significant fibrosis, irrespective of platelet count or, fibrosis score on whatever means you've got, be it a transient elastography, that patient should undergo varicose screening. I mean, I respect the guidelines, but what I'm trying to say is anyone who has cirrhosis or advanced fibrosis, by whatever means, even if it's just upper score or FIB4, those patients should undergo varicose screening.
So we do the variceal screening, and from a practical point, you did mention it on that one slide where there's like a flow diagram and how you manage patients who come for screening and for primary prophylaxis. But practically, it's simple in my mind. If there are big varices that I'm worried about, I'll ban them. But and you also mentioned it. The important thing is once you start banding, you commit to eradicating the varices, and that's, I think, something that doesn't always get done well. You then have to scope the patient in the beginning. I would say 2 or 3 weekly until the varices are a lot better, and I do think that initially there's a slightly increased risk of bleeding after you've banded them, because when the bands slap off, they could bleed. So you're doing it because you think those specific patients are higher risk. Obviously, the patients that have got smaller varices, you're just going to give beta blockers to. So I think, if you're going to go with banding for primary prophylaxis or secondary prophylaxis, when you do banding, it's eradication of varices. It's not a once off. This with regards to tips, I think it's something that gets done well because it's not widely available. It's something that doesn't get done enough. If you look at the studies, and you showed that first study, I think it's by Garcia or some the New England study that you showed. There's a survival benefit on doing early tips in high risk patients. Okay, and that's because you prevent early rebleeding, and the patients have a better 1-year survival. So the question is, why are we not doing it? And it's purely an availability thing. Even in the States, only about 10 or 20% of patients who are candidates for early tips get early tips. But I think we should be encouraged. We as gastroenterologists, we should be trying to encourage people to do more tips. And I'm certainly trying to get more tips done at Groote. And so doing early tips ideally. I think in high-risk patients. The other thing is, if someone has bled, and you also mentioned it, and they're coming for their regular endoscopies, and they bleed despite that, I think that patient should get a TIPS. Okay. Most patients have been getting salvage TIPS, and that's sort of like a different story. So, you know, you have a patient who fails endoscopic therapy, ends up with a tamponade, and then you deal with it. I think another point, anyone who's doing emergency scopes for bleeding needs to have a Senstarken tube and ideally a Dana stent available. Dana stent is different to the other stents in that they've got a bigger diameter. I know that they're not always around, but you almost have to plan it. The way we secure our Senstarken tubes is with a tennis ball. So instead of having a weight, you cut a slit in the tennis ball, you blow up the gastric balloon. You must be 100% sure the gastric balloon is in the stomach. So you put the Senstarken down, you go down with the scope, you see that the gastric balloon is in the stomach, you blow it up with 200 mils of air, you then pull it back till it's tight, and then you make the little slit in the tennis ball and you put it, that slit over it so it holds it at the mouth. And that works quite well, because to get weights and things is quite problematic. What else? Yeah, terlipressin, so octreotide is what we've always used. Terlipressin is nice because you don't have to run an infusion, but as you mentioned, there's a risk of ischemic complications. We've started using it in the odd patient. I haven't come across an ischemic complication, but they're well described. So you shouldn't give it to vascular paths. Maybe Masheko and Neliswa, you can just shed some light on this for me. Is terlipressin not a better drug than octreotide for patients with hepatorenal syndrome?
So I discussed this in the fellows weekend. Number one is your octreotide. Terlipressin is a second class citizen. So yeah, octreotide still wins, I think, on all fronts in preventing and or treating hepatorenal syndrome. And Marc, I don't know if you've noticed in the chat, there is a question about anticoagulation in splenic vein. Maybe you want to comment on that?
Yeah, so I think if it's an acute thing, then it does make sense to anticoagulate. And that's the same for portal vein thrombosis. If you get it acutely, but you need to be sure that there's no varices before you do it. I think a lot of the time these things are diagnosed long after the fact, and most of those patients I don't think benefit from anticoagulation, especially if there's large varices. You've got to weigh up the risk benefit, and what are you trying to achieve by anticoagulation? You're basically trying to stop propagation of the thrombus. So if it's an acute process, you know that's what you're trying to do. If it's just a portal vein thrombosis, you don't want it to extend to the SMV. If it's in the splenic vein, you don't want it to extend to the portal vein and SMV. So that's what you're trying to achieve. Just one thing about gastric varices, I mean, I think that's apart from us doing more tips, gastric varices is an area where there's a lot of developments. One of the things is a lot of people don't know how to inject glue. And there's a whole, like if you speak to an interventional radiologist, liquid embolics is a whole subject in itself. And you can learn a lot by going to spend some time with a good interventional radiologist who does this. So we use just the normal glue that people stitch or use to glue wounds together that's available in most hospital casualties. It comes in little vials of 0.5 mils. So what I usually do is draw up 2 of those. So that will be 1 mil and a 2 mil syringe. And I draw up 2 or 3 of those syringes. And then the best thing to use, we used to use propofol, but the best thing to use is actually 5% dextrose or just plain water, but it has to be distilled water. So nothing that's got ions like sodium or potassium. If you use 5% dextrose, it won't make the glue set. So you get a needle and you go down the scope, and you want the needle to go into the lumen of the vein, like when you're putting up a drip. So you can prime the needle with a 5% dextrose. You then put 1 mil of the glue down the needle, and then you flush through or chase the glue in with 5% dextrose. And often you almost see the vein like change shape as the glue goes in. And then you take the needle out. You've got to be careful not to glue the scope closed. And I discard that needle. I only use it once, because if you're going to inject another one, if the needle's blocked and you stick it into another varix, you're going to cause that varix to bleed. So I use the needle once and then discard and then use another needle. So that's how you inject glue. And then one of the problems with gastric varices, like with esophageal varices, you see that they're eradicated. With gastric varices, you just still see a gastric varix. It looks the same, more or less the same after you've injected the glue. So endoscopic ultrasound is very, very useful in gastric varices to go and check if there's still flow in the varix. So I often do that just to see, after you've injected the glue, have you obliterated it? And I think glue is the first line agent. The other thing you can do is you can coil varices with the EUS scope, and that's the first few times we did that well, actually every time I've done it, we have an interventional radiologist there, because we're not that used to using coils and getting the size, but you basically go with a normal EUS needle, you stick it into the varix, and you feed the coils into the varix through the EUS needle. But I would not inject glue through that, because if you glue, it's one thing gluing up a gastroscope, that's bad enough. But can you imagine gluing a EUS scope? That would just be a disaster. So that's how we do it. Yeah. And then also what I've done a few times with the gastric varices, I mean, I've had it where you stick a needle just for gluing into a gastric varix and it sort of explodes. So if it's really, really big, sometimes it's quite nice to do BRTO. And at the same time as the BRTO, you can coil it. You do them like, so you're almost coming at it from both sides. That also works really well. Yeah. Any other comments or questions? Are there? Then just with regards, so we mentioned tips. Another thing, when a patient comes in with varices, I always think the first thing you should be thinking in every single time a patient comes in with varices is, what is my bailout going to be if I can't stop the bleeding? So your initial bailout is going to be tamponade, balloon or stent, okay? Then you're going to have to think, okay, now what? So then you have, there's really, the options are tips, splenectomy, devascularization, splenectomy and devascularization, and a surgical shunt. We hardly ever do surgical shunts anymore. It's almost historical, and it's very occasionally that we do it, and certainly not usually in an emergency situation. If a patient has a portal vein thrombosis, you can't do a TIPS. Then the bailout will be a splenectomy and a devascularization, and you basically take out the spleen and you go along the lesser curve and the greater curve, and you divide all the big collaterals going right up past the esophagus. And we know in the past people used to transect the esophagus and reanastomose. We don't do that anymore, but you do that. And I mean, it can be quite a bloody operation, and you have to have an anesthetist who's prepared and a cell saver and lots of blood, but it works well, and it's your bailout if you can't stop bleeding in patients with a portal vein thrombosis. Yeah, Elisa.
Thanks, Marc. What is, the role of a physician in a patient who presents with an upper varice or a varical bleed? Des mentioned that the targets is just hemoglobin. Maintain that hemoglobin between 7 and 8, and ignore the coagulopathy. I often get a bit itchy when you have a patient who's got an INR that is prolonged and they're thrombocytopenic. What do you do? Do we ignore those and just focus on?
Yeah. So it's good. It's a good question. So I think INR and platelet counts and all of those things are not good investigations in patients with liver disease. And in liver transplantation, that thromboelastography was developed for patients who are having liver transplants. And TIGs or thromboelastographs are becoming much more widely available. They're often, like, we've now got them in casualty, in ICU, and in theatre. And I would rather, I mean, the only reason I do an INR is to work out the Child-Pugh score and the MELD score. I don't think it's a useful investigation otherwise. I mean, obviously, if it's 10, you know, but I would do if you can, do a thromboelastogram, and it tells you exactly how the patient's clotting. It gives you a much better idea of what you need to give the patient. And I do thromboelastograms in all of these patients. So like today, we had a variceal bleed that came in, and they'd taken 1 tube of blood, and they were going to send it for INR, and you can use that tube to do a thromboelastogram. I said, no, I'd rather have the thromboelastogram, and then you know what to give. So, and I think there's increasing evidence to support that. We also, in patients with obstructive jaundice, you'll get, we've done a little study on it now, and one of our Regis has done the MED on it. And if you do thromboelastograms on all the patients who come in with obstructive jaundice, and you look at the ones who have high INRs, often the thromboelastogram is normal, and some of the patients with high INRs actually are hypercoagulable. So yeah, it's not a good investigation. Rather do TIGs.
Marc or Nelly?
Oh, another thing. We have a variceal checklist that I've drawn up with Criticia. So for me, another thing that I think is important and is, once a patient's stable, I always get a CT scan if it's their first bleed. You know, we used to do ultrasounds. I think in this day and age, a CT scan is much better. And you want to, the things I want to know in a CT scan is, I want to know, is there a hepatocellular carcinoma? So patients with hepatocellular carcinoma often have invasion into the portal vein that bumps up the portal pressure. It's often a presenting feature of patients with large HCCs. You could argue you're going to see a large HCC on a CT scan, but sometimes you don't. I also want to know exactly what the portal venous anatomy is. You know, is the splenic vein patent? Is the portal vein patent? How big is the spleen? You know, you just get, I feel you get more information from a CT. So we CT scan every single patient who's had a variceal bleed now when they come in. And then I find it very irritating if a patient gets presented with a variceal bleed and no one has bothered to work out the Child-Pugh or the MELD score, because, you know, that just is, I mean, most of these patients have cirrhosis, and that's often the determining factor in the survival of these patients. So we know at Criticia, in the last 30 years, we've not had one patient who's Child-Pugh 14 or 15 walk out of hospital alive. So, you know, you've got to bear that in mind. Whereas if you've got a patient who's Child-Pugh A, you should be going all out on that patient, and you can fight for that patient to go to ICU. Patient who's Child-Pugh 15, like you mentioned, futile tips, virtually everything in that patient is going to be futile. So, you know. And Elisa says, I don't trust the ultrasonographers. Yeah, I don't. And I like to be able to see what's going on with all of that stuff. And, you know, if you're going to be planning surgery or tips or whatever, and if you're going to do a tips, the interventional radiologist usually wants a CT as well.
I don't trust them either. I'm sorry to say. I hope they're not on the call.
The only thing that you can see differently on the ultrasound is you can see the direction of flow in the portal vein, but I don't know that makes any difference to anything. Yeah.
Nelly, do you mind if I ask you just to clarify for the fellows, if you have a patient who's cirrhotic with portal hypertension and ascites, when do you use diuretics, when would you not, and what about the non-selective beta blockers, because they're typically lowish blood pressures and whatnot? So just for the fellows, just some simple guidance on how to manage that situation.
Okay, guys, please ignore the background noise. I've tried to stay away from the kids. So if you have a patient who's cirrhotic and has decompensated, a decompensation is anything from variceal bleed, ascites, and or jaundice. But Mashiko's specific question is ascites, right? Any ascites or any detectable fluid in the abdomen warrants a diuretic. Your first line diuretic, depending on how massive or how big the ascites is, your spironolactone. So ideally, you will start with spiractin. If they've got moderate, you'll add both spironolactone and Lasix. We usually like if you're going to give them 50 spironolactone, 40 milligrams of Lasix. If you're going to give them 100, if they can tolerate while watching, obviously, the creatinine and the sodium with the spironolactone. If you're going to give them 100, you're going to give them at least about 80 Lasix. But the more spironolactone, the better, because of the mechanisms of portal hypertension and or ascites as described by Des in her first few slides. And as I was sort of trying to explain that if you have a patient who comes in and they've got a nodular looking liver with a surface that is suggestive of cirrhosis, a sluggish flow on that portal vein with ascites, those are your patients that you screen for varices. Now, primary prophylaxis is something that is all around debatable. We all know our restrictions, but not as bad here in South Africa as is in others, African countries. So those are the patients, if you think that they've got significant portal hypertension or clinically significant portal hypertension as measured by that platelet count and or whatever means of fibrosis score, you can start them on prophylactically low dose carvedilol, which is 3.125 or 6.25 milligrams daily as monitored or as tolerated by their blood pressure. So start slow, build up. If patients have got large volume ascites, the best thing you can do for them, instead of just working them with diuretics that are not going to work initially, is to perform those large volume paracentesis. Obviously, they work wonders if you've got albumin. So you tap, tap, tap until that ascites is controllable and you're happy that they can actually absorb or start absorbing those diuretics. So with moderate to severe ascites, we combine paracentesis with diuretics. And again, we're not greedy when we introduce the diuretics. Slow does the trick, and the best is to build up, because if you work them with massive dosages of diuretics, then you lose the kidneys fast, and then you're stuck with what you can do. So low dose, build up. If it's large volume, tap. If you can scope them and they've got mild or whatever varices and even no signs of bleeding, a beta blocker. And the ideal or the most preferred and the one that works wonders is your carvedilol, and the daily dose is sufficient. Single dose, improved compliance, great benefit. And that will be my approach, Mesh, in these patients who have decompensated cirrhosis. Thanks.
Thanks, Nelly. That was very, very clear. Thank
So
you.
just another practical thing, when you get one of these patients, I mean, it can be an absolute terrifying bloodbath. Just when you go down, always, even if you think it's a variceal bleed, or even if you're doesn't matter, even if you're doing a scope for someone who's coming for primary prophylaxis, always go down without the bander on first, because you see much better. And then try and figure out what's going on. You need to make a decision, and it's the same as a trauma laparotomy. You don't want to flounder around for 15 minutes messing around. Decide early on if you think you're going to control the bleeding with banding, and then do it. If you don't take much longer than that. If it's taking long, then you want to stop the bleeding and you must institute tamponade, whether it's balloon or stent tamponade, because then you don't want the patient to become hemodynamically very unstable for a prolonged period of time. You want to stop the bleeding, resuscitate the patient, and then bring it back a patient who's now, not acidotic, cold, coagulopathic, and then have another go at stopping the bleeding once you got a better patient. So there's a lot of similarities to trauma patients because of the bleeding, and you want to avoid hypothermia, acidosis, coagulopathy. If there's not,
There's Siraj in the panel. Maybe any words of wisdom from your end, Siraj, saying that Des is your fellow, or rather a gastroenterologist now.
I think Des has covered most important things. Bleeding varix tests all endoscopists. I remember my first big one with Marc in theater. That night we didn't win. I don't even remember that, Marc. And then I remember also injecting a small bowel varix via the double balloon scope.
Yeah.
That was also scary.
Yeah. No, I mean, it's the, in surgery also, we always say, like, you'd much rather have bleeding from an artery than from a vein. Venous bleeding is just horrible. It's just this upwelling of blood, and you know, it's just, yeah. And sometimes just tamponating is the best thing to do. Obviously, you can't do that for the distal ones. Yeah. I think it's one of the one of the most difficult things that we have to deal with as endoscopists, and I think I'm hoping that TIPS is going to become more widely available in South Africa, and I think it'll make our lives easier instead of trying to, like, if you think about it, we're just trying to sort out the problem very superficially, whereas TIPS at least deals with it properly.
Marc, have you dealt with lots of bands falling off and causing massive bleeds? We've had 2 in the last year. One had a good outcome and one had a terrible outcome.
Yeah. So I've tried lots of different types of bands. I've tried the Boston ones. We use, I don't even know what the name is. I think it's, and then obviously the Cook ones are the common ones. It's really important that you have strong suction when you do it. You really want to suck that varix in. You don't want to let it go. Sometimes when patients have had lots of banding and there's lots of scar tissue, it can be difficult to suck the varix in, and very occasionally in those patients, sometimes injecting glue can be better.
So we saved somebody by putting in a metal stent in the one that bled, because we knew you couldn't get control. And then luckily, she was a pregnant lady, so we saved her. I think we were just lucky. We were just lucky that day.
So I see now that they've stopped supplying the Danner stents. I know definitely in private. I've got a stash of them at Critical, and we've used a couple now. So I'm actually going to try to find out because I mean, I think Danner stents are great. Obviously, they don't work for gastric varices, but I mean, if we can't get them anymore, then we must make sure that we've got Senstarkins around as well. The big problem with the stents is migration. Yeah. All right, I think it's almost 7 o'clock, so I think we can end that if everyone's happy.
Yeah, no, awesome. Great. Thanks,
Okay.
thanks, guys. Thanks, Marc. That was
Okay,
brilliant.
Yeah.
Thanks.
Okay. So thanks to everyone. Thanks to Echo University of New Mexico and the Echo India team. Recordings of this will be available on the Gastro Foundation website. Thank you to the Gastro Foundation. And the next presentation is by Isneen Hilmi on the 27th of May on upper GI bleeding, the easy type, the non-variceal type. All right. Cheers. Thanks, guys.
Thank you. Thanks, Marc.